Injuries to the anterior cruciate ligament, or ACL, are very common, and most of us are aware of ACL injuries from seeing professional athletes on television injuring their knee during a game of sport. In my practice, I do see and treat ACL injuries amongst elite athletes in the AFL, AFLW and the NBL. However, the bulk of my patients with ACL injuries are what I would call weekend warriors. Regular, everyday people that enjoy getting out and playing some sport on the weekends, or just keeping fit and active. I have a special interest in ACL reconstruction, and I have to admit it's probably my favourite operation to perform. I treat over 200 ACL injuries every year in both adults and growing athletes. There are many misconceptions about ACL injury, especially when it comes to understanding exactly what an ACL injury is and what your treatment options are. There are different treatment options for every patient, depending on the severity of your injury, your age, your occupation, and also what types of activities you enjoy. Now, unfortunately, this educational video is not going to be short, but it is for a good reason. This is a very complex topic and it will take some time to guide you through it properly. I'm going to talk to you about what the ACL is, how it's injured, what other injuries are associated with it, what the treatment options are, and also what recovery looks like for most patients. So if you're after a brief summary about ACL injury, then check out one of the shorter videos on my website. The anterior cruciate ligament, or ACL, is one of the most important stabilising ligaments in your knee joint. So this is what your knee joint looks like with all the skin and muscles removed. This is the thigh bone or femur, and this is the shin bone or tibia. Most people realise that the knee joint moves back and forward like this, but it's not just a hinge joint. It also rotates or pivots like this. The knee is the largest and most complex joint in your entire body. In fact, today we are still learning more and more about how complex this incredible joint is, and the different ways it moves as you perform various activities. The ligaments inside and outside the knee joint play an important role in preventing it moving too far in any one direction, and this keeps your knee stable and stops it giving way. This is the ACL here, going from the top of your shin bone and up into your thigh bone. When you look inside a knee joint, the ACL looks like a white shiny rope that is connecting the two bones together. It's also tightly tensioned to keep the knee stable. The ACL's main job is to stop your knee over-rotating or over-pivoting. This is especially important when you are moving from side to side or changing direction quickly. It also plays a role in preventing your shin bone moving too far forward. These are exactly the types of movements you would perform regularly in a variety of sports, especially if you were trying to dodge around an opponent in, say, a soccer, football or rugby match. The ACL also prevents over-rotation when you are landing, say after jumping up to catch the ball in netball or basketball, and then coming back down and planting your foot on the ground. There are other ligaments in and around the knee joint, and they prevent your knee moving too far in other directions. However, what most people don't know is that ligaments are really the last line of defence in your knee giving way. The muscles in your entire lower limb are far more important in stabilising your knee joint. These muscles in your hip, buttocks, thigh and calf all work together to move and stabilise your knee as you perform various activities. Now you can imagine how complex this process is, with all these muscles working together without you even having to think about it. Subconsciously, your brain is switching various muscles on and off and adjusting how hard they are working to help you perform very complex and sudden movements. Most ACL injuries are non-contact, which means you don't usually collide with an opponent or receive a knock to your knee. It simply gives way without warning. The main reason this happens is that for a split second, there is a lack of muscular coordination and additional force is placed through your knee joint. With the muscles momentarily failing to do their job, the ACL is asked to resist more force than it can deal with, and it ruptures. We call this a pivot shift injury, and it looks a bit like this. You can see how the knee is over-rotating and the ACL is being stretched until it finally ruptures. Your ACL can also rupture due to a direct blow or collision, but this occurs less commonly than non-contact injuries. Many of my patients are often surprised with how easily they ruptured their ACL. It can happen very quickly and sometimes without a lot of pain or swelling. Now, the ACL doesn't snap in half with a clean break, like most textbooks and online pictures suggest. It actually explodes. A ruptured ACL often looks like two ends of a mop sitting inside your knee. This is why I tend to think of the ACL exploding rather than just snapping in half. Because the ACL is so damaged, it is unable to heal or repair itself. It will never return to the same shape and function. This is different to other ligaments around your knee joint that can commonly heal very well without surgery. Your ACL also doesn't have to completely rupture to cause your knee to be unstable. Now, this is a really important point and it causes a lot of confusion amongst the patients that I treat. Imagine your ACL is an elastic band. If you stretch it a little bit, it can spring back into the same shape and keep on doing its job. However, if you really overstretch that elastic band, it will never return to the same shape, springiness, and function. This is exactly what happens to your ACL if it is overstretched. Even if it hasn't completely ruptured, it can no longer spring back to its original shape and tension. When you look inside a patient's knee with this type of stretch injury, the ACL looks very floppy and redundant. You can see how this ACL is just not going to do its normal job. And many ACL injuries present like this. This is why an experienced sports physiotherapist, sports physician, sports doctor, or orthopaedic surgeon needs to examine your knee carefully if you are suspected of having even a mild ACL injury. For example, your MRI scan may be reported as showing just an ACL strain. But as we have just discussed, even a badly strained ACL can be the functional equivalent of a complete injury. Even the best MRI scans are not 100% accurate, so knee examination is the gold standard for assessing the severity of your ACL injury. Some patients will be lucky and there will be enough tension left within the strained ACL to allow it to return to normal function without surgery. If we could look inside a knee joint in slow motion during an ACL injury, we would see that there is a massive force going through the knee joint, and the knee probably comes close to completely dislocating. It's for this reason we should not think of an ACL injury as involving just a torn ACL. It involves your entire joint. When the ACL ruptures, the thigh bone and shin bone collide very heavily with each other. This can cause a huge amount of damage to the bone beneath the cartilage in your knee joint. You can see this bone bruising clearly on an MRI. Normally, the bone on the thigh and shin would be black, but bone bruising looks like someone has spray painted the bone with white paint. This is bleeding and bruising within the bone, and I often compare this to having a corky in your thigh from a knock during sport. The muscle bleeds, swells, and is painful for a long time. The same type of process is happening in your knee bones after an ACL injury. Bone has a very rich blood supply. It's not dry and lifeless like we see in a skeleton at the museum. It bleeds just like muscle. This is one of the reasons your knee can be so sore after an ACL injury. It may take 6 months or more for this bone bruising to resolve, and this is one of the reasons ACL recovery does not happen overnight. But the biggest problem with this bone bruising may not be seen for several years after your injury. The same force that caused your bones to bleed was also transmitted into the smooth cartilage that covers the ends of the knee bones. Now, this is called articular cartilage. Unlike bone, cartilage cannot repair itself back to normal. We think that the bone bleeding and the force the cartilage was exposed to both play a role in some patients developing arthritis in their knee, many years after an ACL injury. Now let's take a look at how ACL surgery works. Because the ACL is so badly damaged when it ruptures, we can't physically sew it back together. It just won't heal anywhere near enough to function normally. That's why we need to perform an ACL reconstruction, or completely replace the ruptured ACL with something else. What we do is basically borrow a tendon from somewhere else in your body to take the place of your injured ACL. We call this borrowed tendon a graft. There are a number of good graft options for ACL reconstruction, and these include your hamstring tendon, kneecap tendon, and quadriceps tendon. Your surgeon can discuss which option is most suitable for you. In Australia, hamstring ACL reconstruction is the most common. Synthetic ligaments, such as a Lars ligament, are an option, but I do not recommend them, as their long-term results have been inferior. In growing athletes, there is also the option for mum or dad to donate one of their hamstring tendons to reconstruct their child's knee. I do offer this option, but in general it is only required in younger children. For the purposes of this video, I'll explain hamstring ACL reconstruction because that is the most common. However, no matter what graft your surgeon uses, the basic principles remain the same. You'll usually be in hospital for one evening after ACL surgery, but you may also choose to go home on the same day as your surgery. The surgery takes place via 3 keyhole incisions, 2 small incisions about 5mm in size, either side of the kneecap, and 1 incision about 3 cm in length over the inside of your shin. Several months after surgery, these scars are almost unnoticeable unless you looked very closely for them. You have 4 hamstring muscles. They begin high up in the back of your thigh, near your gluteal or buttocks muscles. As your hamstring muscles run down the thigh, each one of them eventually turns into a long, thin tendon, which looks a little bit like a thick piece of string. The hamstring tendons that we use for ACL reconstruction continue down the back of the thigh and eventually attach to your shin bone at the front of your leg. I use a technique called single hamstring ACL reconstruction, meaning in most patients I only remove 1 hamstring tendon. This tendon is then quadrupled to make a 4-stranded graft that is very thick and strong. This will become your new ACL. You can gain an idea of how this works by demonstrating with a piece of cord. The traditional hamstring ACL reconstruction technique involves removing 2 hamstring tendons and turning these into a 4-stranded graft. I prefer to only remove 1 hamstring, as this leaves the other hamstring in place to continue working normally. It also means less muscle damage and typically gives a thicker, stronger graft. There is increasing evidence that the thicker a graft is, the lower the risk of ACL re-rupture. Your hamstring tendon will not completely regrow to its previous shape and size. However, the hamstring muscle will usually form a similar looking tendon from scar tissue. After complete rehabilitation, there is surprisingly little effect upon the hamstring muscle's function. For example, if I use the single hamstring ACL reconstruction technique on an elite athlete, I would expect them to make a full return to professional sport in the future. A small camera and other instruments are placed into your knee joint through the 2 smaller incisions. Firstly, we carefully inspect the entire knee joint for any other damage, such as a loose piece of cartilage in your joint or a meniscal tear. Even if your MRI scan has not shown a meniscal tear before surgery, we'll often discover that you have one and repair it with suture material. MRI scans, as I've previously mentioned, are not completely accurate, but an arthroscopy of your knee shows us everything in fine detail. A repaired meniscus, along with an ACL reconstruction at the same time, has a very good chance of healing. Most of the torn ACL fragments are then removed from the joint. Otherwise, they will cause clicking and catching within the joint and potentially stiffness. A small tunnel is then drilled into the thigh bone and the shin bone, and these tunnels are exactly the same size as the diameter of your hamstring graft. The ACL graft is then positioned into these 2 tunnels and firmly secured in place. Secure fixation of the graft allows patients to mobilise early, without fear of the graft losing tension. And that's the basics of an ACL reconstruction. That hamstring graft across your knee joint is now acting like the ACL used to and stabilising your knee. The graft fixation only plays a temporary role with securing the graft inside your knee. Within 6 to 8 weeks, your body has healed the graft quite firmly into both ends of the bones, and the implants no longer play a role. But this is where it starts to get really interesting. Specialised cells from the bone marrow slowly migrate into the graft. Incredibly, these cells will almost completely dissolve away the graft and then rebuild it. The graft acts a bit like a scaffold on a construction site, allowing this healing to occur. Once fully healed into your knee joint, the graft is a living, breathing tissue, even with its own blood supply. When this process is fully complete, it's hard to actually tell a reconstructed ACL from a normal ACL. Even though I perform ACL reconstructions almost every week, I still find it quite amazing that our body is able to achieve this process and turn a hamstring into a living, breathing ACL. Now, the positioning of the graft inside your knee is one of the most crucial aspects of the operation. Your surgeon needs to position your reconstruction in exactly the same position as your normal ACL. Now, this might sound pretty simple, but by placing the graft even 1 or 2 millimeters away from the correct position can lead to significant problems after surgery, and also increase your risk of re-rupturing your graft. This is one of the reasons that I believe that ACL surgery should ideally be performed by surgeons who regularly carry out ACL reconstructions. You should feel comfortable asking your surgeon how many ACL reconstructions they perform. Don't forget, there is generally no rush to have your ACL reconstruction, so you have plenty of time to do your research and select a surgeon that you are confident with. The genuine unsung heroes of your knee joint are these horseshoe-shaped, shock-absorbing cartilage pads called a meniscus. They are completely different to the articular cartilage that covers the ends of your knee bones. Meniscal tears are commonly associated with ACL injuries. Now, I have a complete video on meniscus injuries on my website, so check that out for more specific detail. But for now, here's a brief summary in relation to ACL injury. A meniscus is made from a rubbery form of cartilage called fibrocartilage, but they're not just shock absorbers. They also play an important role in stabilising your knee joint. If a meniscus is permanently damaged and eventually requires removal from your knee joint, you can quite rapidly develop arthritis at any age. We tend to think of arthritis as occurring only in elderly patients, but it's not uncommon for me to see signs of arthritis in younger patients' knees after a meniscal injury that did not heal. Some of these patients are still school-aged. This shows you just how important a meniscus is for your knee health. A meniscus has a very poor blood supply and therefore has a very limited healing potential after being torn. Some young children may have some capacity to heal a torn meniscus without surgery, but the majority of meniscal tears will never heal unless they are surgically repaired with suture material. Meniscal tears associated with an ACL injury are even less likely to heal without surgery. Now, not every patient requires surgery to adequately recover from ACL injury. It's very important that you talk to your surgeon about your specific health history and lifestyle before making a decision that is right for you. Your physiotherapist is also a great person to talk to, as they would have seen many patients recovering from ACL injuries over the years, and they can give you really important advice. In general, older patients who do not have a demanding manual job or play sports or have hobbies that involve side-to-side movement may cope quite well without surgery, even if their ACL is completely torn and not functioning properly. Remember how I spoke about the most important stabilisers of your knee being muscles, not ligaments? In the types of patients that I've just mentioned, your physiotherapist can take you through a rehabilitation program to strengthen and better coordinate these muscles, and this will compensate for the lack of normal ACL function. Now, it may be 6 months or more until we know if this physiotherapy treatment has been successful, and we mainly gauge that by whether or not your knee is giving way and causing problems during the activities that you perform every day. With this non-surgical approach, I would not recommend that you played sports that involved side-to-side movement, as there would be a considerable risk that your knee will give way again, and this could lead to more damage to the articular cartilage and meniscus in your knee. But you should still be able to maintain a very active lifestyle and cope with straight line activities like walking, hiking and swimming. In general, younger patients who wish to return to high demand occupations or side-to-side sports and hobbies should consider ACL reconstruction. These patients may still choose to trial non-operative management. There is just a higher chance that this may not be successful. You have to balance up the pros and cons of potentially delaying your eventual ACL surgery and recovery by 6 months or more if your trial of non-operative management fails. And for most patients, this would mean missing another entire season of sport. Patients with a significant meniscal tear in most age groups should strongly consider ACL surgery. The meniscal tear will not heal unless it is repaired, and meniscal healing rates without ACL reconstruction at the same time are very poor. This is because the unstable knee creates too much movement and shear force over the meniscus. This tends to pull the meniscal sutures apart before healing takes place. ACL reconstruction also helps with other biological aspects of meniscal healing within the knee joint. Growing athletes, or school-age children, have a predictably poor outcome without ACL reconstruction surgery. Even if these patients don't play sports, the high demands of their young age and lifestyle often leads to ongoing instability of their knee. This causes further cartilage and meniscal damage, and there is a high risk of knee arthritis later in life. Of course, every child is different, but in general, this is my recommendation. ACL reconstruction in growing athletes should be performed by an orthopaedic surgeon with specific subspecialist training in paediatric ACL reconstruction. Children are not just little adults, and the surgical technique they require compared to adults is different. It's very important that you ask your surgeon if they have this level of training. ACL reconstruction in children is safe and effective. I perform ACL reconstruction in children as young as 8 years of age, but fortunately, ACL injury in this age group is quite rare. The bulk of the ACL injuries we see in children occur in adolescence. Because children are still growing from the bones around the knee joint, there are some additional risks that you'll need to discuss with your surgeon. Approximately half of the ACL reconstructions I perform are in growing athletes. And being a parent myself, I can understand how much stress and anxiety an ACL injury causes mum and dad. But I'm also constantly amazed at how well children cope with the surgery and the recovery. When treating growing athletes, I focus a lot of time and attention actually talking with that young patient. Although mum and dad's opinions and questions are very important, at the end of the day, we need your child to take ownership of their injury and their recovery. And the best way of achieving this is to allow them to make informed decisions about their own knee. Of course, mum and dad and your surgeon will play an important role in helping them make a decision, but they need to feel confident that they are in control. Once the graft is positioned into your knee, your wounds are closed with sutures and a dressing is placed on the skin. After surgery, you will feel some pain and discomfort up the back of your thigh and behind your knee. This is where the hamstring was harvested from. You will also have some discomfort and swelling in your knee. However, the majority of patients are not in extreme pain, even shortly after surgery. You are allowed to get up and mobilise on your knee as soon as you feel comfortable. You can put as much weight through it as you like, but most patients will need to use crutches for 3 to 7 days until they can safely walk without them. Your physiotherapist will guide this process. I recommend 2 weeks off work for most patients. You may be able to return to light office-based duties within 1 week, but 2 weeks is more realistic. Even though this is a keyhole procedure, it is a significant operation, and you will have pain and swelling, especially if you spend long periods of time on your feet. You could drive a car within 1 to 2 weeks, depending on your pain and swelling, and also which leg you have had surgery on. During your hospital visit, you'll be seen by a sports physiotherapist, and they will get you started with a 2-week rehabilitation program by showing you exercises that you should perform at least 3 times per day. I cannot overemphasize enough how important rehabilitation is when recovering from ACL reconstruction. Patients who do not put in a regular effort, overseen by an experienced sports physiotherapist, can expect much poorer results. Full ACL rehabilitation takes a minimum of 12 months, and maintaining a regular injury prevention program with your physiotherapist is also highly recommended, even after your initial rehabilitation program is finished. Swelling can persist within your knee for several months. Remember that it takes 12 months for that graft to fully heal inside your knee. And your knee is also recovering from a very large injury. You absolutely must book an appointment to see your own physiotherapist within 1 to 2 weeks of leaving hospital. If you don't already have a physiotherapist, I can certainly recommend one. It makes sense to see a physiotherapist who is close to where you live or work, otherwise you'll be less inclined to see them regularly. Good ACL rehabilitation is not time focused, it is goal focused. We don't accelerate your rehabilitation purely according to how long it has been since your surgery. You progress based on achieving goals. These might include range of motion, swelling reduction, or strength improvement, for example. I'll provide your physiotherapist with a basic rehabilitation protocol, and they will use this along with their preferences and experience to take you through a 12-month rehabilitation program. Whilst there is variation in rehabilitation, I can give you a basic outline of progression that should apply to most patients. By 2 weeks, you should be walking without crutches, but you may still have a limp. You can also cycle on an exercise trainer as soon as your knee has sufficient bending. By 6 weeks, you should have full range of motion, reduced swelling, and walking without a major limp. By 3 months, you can start jogging gently in a straight line. At 6 months, some supervised jumping, landing, and leaping can begin. At 9 months, you can commence some sport-specific training, which means doing some of the activities of your chosen sport, but in a non-contact environment. From 9 to 12 months, your training and activities will gradually progress, with the aim of returning to full sports by about 12 months after surgery. ACL reconstruction is safe and effective for patients of all ages, and complications are fortunately rare. However, like any operation, there are some risks. Skin infection occurs in less than 1% of patients, and is mild if it does occur. You may require some tablet antibiotics if this happened, but there would be no long-term consequences. The risk of a deep infection inside the knee is very rare, less than 1 in 1,000 patients. If this occurred, you would require another keyhole operation to wash the infection out, and antibiotics for a number of weeks. It is not uncommon for patients to have a numb patch of skin on the outside of their leg. This is due to very small nerves about the size of a human hair being cut through when the skin incision is made on your leg. This will cause no functional problems, but it may feel unusual. It can improve significantly over a 6-month period, and taking 500 milligrams of vitamin C twice a day for 3 months will assist this recovery. In some patients, the decreased sensation can be permanent. It may take 2 to 6 weeks for you to get your knee fully straight. Ideally, you would achieve this by 2 weeks, but in some patients this takes longer. Pain, swelling, and scar tissue formation within your knee can all limit this. If your knee remains stiff for 3 months or longer, then you may require another keyhole operation to remove scar tissue from your knee joint, to improve your range of motion. Rarely, a patient may never regain their full knee straightening. The risk of a blood clot or DVT is low after ACL reconstruction. Most patients will not require any blood thinning medication. There is a risk that you could re-rupture your reconstructed ACL. The risk of re-rupture depends upon your age, gender, type of sport you wish to return to, and also how much time and effort you put into rehabilitation. You are actually more likely to rupture the ACL in your other non-injured knee than you are your reconstructed knee. If you did re-rupture your reconstructed knee, then it can be reconstructed again. The recovery is the same as the original procedure. Swelling can persist within your knee for several months. remember that it takes 12 months for that graft to fully heal inside your knee. And your knee is also recovering from a very large injury. When you return to full training and sports, your knee may also swell again for a period of time. There is a longer term risk of pain and arthritis within your knee, largely due to the bone and cartilage bruising that occurred at the time of injury. A severe meniscal or articular cartilage injury will also increase your lifetime risk of arthritis. Lastly, if you've just injured your ACL, here are some tips to help you in the short term. Take regular anti-inflammatory medication along with Panadol. They are safe to take together. Apply a compression bandage or stocking to your knee and elevate it as much as possible. Regular icing can also help. Unless you've been specifically instructed by a sports physiotherapist, sports doctor or orthopaedic surgeon, do not keep your knee in a brace. They usually do more harm than good and lead to weakness and stiffness. Bend and straighten your knee as much as possible. You're not going to do any damage to this. You won't like the feel of trying to get your knee fully straight, but gently try to achieve this. You can walk on your knee if pain and strength allows, so only use crutches if you absolutely need them. Make an appointment with an experienced sports physiotherapist as soon as possible. The sooner your rehabilitation or prehabilitation, if you end up having surgery, starts, the better your long-term results will be. Talk to your GP and physiotherapist about recommending an orthopaedic surgeon. Even if you don't end up needing surgery, it is very important that you see a surgeon to seek their advice, have them examine your knee and review your MRI images. It is usually recommended to let your knee swelling settle for 1 to 2 weeks prior to ACL surgery. So don't worry if it takes some time to see your specialist. You're not doing any harm and it gives you time to think about your options. Because I perform a high volume of ACL surgery, I keep appointments free and available every day, only for patients with ACL injuries. So if you would like to be seen quickly, I can usually accommodate that within a few days. Now I know this has been quite a long video, so thanks for sticking with me. But hopefully you now have a much better understanding about ACL injury and your treatment options. If you do have further questions or you'd like to make an appointment, please give me a call in my rooms at any time.